Hello and welcome to the Duke Cardiology Conference. I'm Sunil V, Assistant Professor of Medicine here at Duke University Medical Center. Today's program is titled BareMetal Stents versus Drug-Eluting Stents in Patients with Diabetes. And our distinguished guest is Mitch Krukoff, Professor of Medicine and Director of the Cardiovascular Devices Unit at Duke Clinical Research Institute here in Durham. Mitch, thanks for being here.
Good morning, Sunil. It's a pleasure.
So Mitch, we're doing a series of programs around a complex patient. And it's a patient today that we're going to discuss that has diabetes mellitus type 2. It's a patient who has been admitted to the hospital with acute coronary syndrome, receives aggressive evidence-based therapy, and then ultimately undergoes invasive risk stratification, and is found to have multivessel disease. The decision is made then to pursue multivessel PCI, and on rounds the discussion centered around how do we choose between BareMetal stents, drug-eluting stents, what type of stent, and what's the evidence base for making that decision? What can you tell us about that?
Well, Sunil, I think clearly it's a complex topic. From the anatomy itself of multivessel disease, the metabolic issues regarding management of patients with diabetes and how they're similar to but different from patients who don't have diabetes. And then the whole issue of when are BareMetal stents most effective, most safe, most cost-effective in our modern world compared to drug-eluting stents, and which drug-eluting stents. I think we're in an era where we can't just lump them all together easily either. So it sounds like we have a complex discussion.
So why don't you show us what you've got here?
So I took on the theme of BareMetal versus drug-eluting stents in diabetics, but as I said, it's a complex discussion. So I took the liberty actually of, it's nice to have friends when things are complicated, and I want to acknowledge that in putting my thoughts and some of these slides together, I got help from some very good friends. Coronary disease and diabetics have a series of key issues. I think first of all, what do we really encounter that's different in a diabetic human being versus a non-diabetic human being? The issue, as acknowledged, of if we use a BareMetal stent platform versus a drug-eluting stent platform has a lot of its own questions. Whether one drug-eluting stent platform relative to another, at least with what we have available here in the U.S., or can look around the world and see what else is coming. And finally, I think we do have to step back and recognize that the question of whether to do percutaneous intervention in a diabetic with multivessel disease also has some issues compared to other therapies, medical or surgical. And all that then ties into a matrix of all the other complexities of just plain percutaneous intervention. This patient presents with an acute syndrome, the age, the gender, ejection fraction, other comorbidities, which of course in diabetic patients, other comorbidities are also more frequent. And the anatomy itself, in this case multivessel, was the left main involved? Are there other kinds of bifurcations, CTOs? All of these are all long discussions. I think as we step back and understand what evidence do we have to compare drug-eluting stents and BareMetal stents, we also have to recognize that from 2000 to 2005, as opposed to 2005 to the current time, the trials available really are in different time periods. And most of the BareMetal stent versus drug-eluting stents, the Sirius study, which brought the Cypher stent forward compared to Velocity, Taxus 4, the pivotal trial that brought us the Taxus stent compared to its BareMetal platform, Endeavor 2, which was the Alamos driver versus the BareMetal driver stent. And most contemporary data, I guess, BareMetal versus DES is in the STEMI population, which is Horizons. But most of the actual head-to-head randomized data that we have is more than 5 years old, planned almost 10 years ago, and recognizing that in diabetes therapy, that 10 years is not a standstill time. So our whole understanding of what's going on in diabetes and what evidence we have to recognize most of the real head-to-head evidence is older rather than newer. Whereas most of the newer contemporary trials that help us understand the evolution of drug-eluting stent platforms do not leave us with head-to-head BareMetal versus drug-eluting stent comparisons. The Endeavor series, the Spirit series, Leaders, the Protect study, these are all now active control drug-eluting stent A versus drug-eluting stent B. So first, I think we have to recognize that the evidence available for BareMetal versus drug-eluting stent is older for the most part, other than Horizons, and I'll spend a little time on Horizons because it is a contemporary trial.
Mitch, let me ask you a quick question. You know, we have lamented in the academic world the lack of active controlled trials for a long time. And yet, as you pointed out in the drug-eluting stent world, we have now a wealth of trials that have done that. Is this something that was driven by the drug-eluting stent market? Is it something that was mandated by the FDA? Or is it simply that the bar has gone higher for new drug-eluting stent platforms to get approved?
I think to some degree it's all of the above. I think obviously the breakthrough of drug-eluting stents available in the U.S. and its adoption rate, as you know, having written a great paper on this topic, that adoption was very enthusiastic and largely driven by the effectiveness that's unequivocally different between drug-eluting stents in restenosis rates compared to BareMetal. And then in 2006, this lingering, very hard to get our arms around issue of what about safety, not in hundreds or thousands, but in millions of human beings with permanent implants, opened a whole other kind of range of concern. So I think a lot of the emphasis currently on active control, DES to DES, is not only part of the natural life cycle of the device evolution, but also the concern about safety. Can we, with newer DES platforms, get away from this lingering concern that maybe when you stop the clopidogrel or the prasugrel, you're suddenly going to have a STEMI on your hands? So I wanted to start with just a broad contemporary view of why and when in general do we use BareMetal compared to drug-eluting stents, because we do, and we continue. The BareMetal market is still a significant market, different in different parts of the world, but in the U.S. it's still around 20%, 25% of the market. And why? So drug-eluting stents, clearly effectiveness across the board, all 4 approved platforms in the U.S. have lower restenosis rates in randomized head-to-head trials than any BareMetal platforms, even modern cobalt chromium platforms. The late safety questions about stent thrombosis, I think, are what have haunted this issue, and how long and what sort of dual antiplatelet therapy goes along with the safety of these devices, as well as the technique for their implantation. What about overlaps? All of these other kind of lingering long-term safety questions. And at the end of the day, although not a primary driver yet in the United States with comparative effectiveness metrics, we may see that the cost effectiveness, the fact that drug-eluting stents are more expensive than BareMetal, may come into play in other parts of the world. That's a very significant part of the equation as well. BareMetal stents, I think, our primary use is still in the setting of patients who we feel are unlikely to be compliant with medication, dual antiplatelet therapy, or are at risk for a physiologic reason to need to interrupt. They have a history of bleeding or stroke, or they need surgery, which is predictable, and we understand they're going to need their dual antiplatelet therapy interrupted. By and large, that's the selection ground, and that pre-procedural triage now I think is much more rigorous and is what sustains this 20 to 25% of patients who we start with BareMetal stents. And then in the STEMI setting, I think the substrate of a STEMI is still, although Horizons has been a huge step toward that, it's going to be a while before we have a 5-year outcome or enough patients to understand the 0.6% per year hazard rate. So I think the question in acute STEMI, where you can't screen the patient as thoroughly because time is muscle, you're moving toward the lab, that at least in the U.S., STEMI, I think, is still at least about 50% BareMetal, or around that number. And to what degree then certain anatomy drivers are behind this? I think right now, basically, we pick drug-eluting stents where we think the safety questions are least, and BareMetal stents where we're concerned about dual antiplatelet therapy or in a STEMI setting. So actually, this is an independent issue of whether or not the patient has diabetes. What about diabetes versus non-diabetic patients? And here I think we all recognize that diabetic arteries are really different because diabetic metabolism that affects arteries and the atherogenetic process is really different. From endothelial dysfunction, which again in a diabetic substrate is clearly different than a non-diabetic substrate, just to how the atheroma forms, what the role of the inflammatory system is, how likely lipid pools or plaque ruptures are to form in that substrate. And then once you manipulate a lesion, once we explode the lesion with a balloon and embed steel in the middle of it, how likely is the inflammatory response to generate restenosis? All of these features are clearly different in diabetics through a variety of redundant mechanisms. So it's not like there's one clear target that we could focus a single drug on. It's a very broad end organ influence of this underlying genetic metabolism. And that's why when we look at lists of baseline characteristics in diabetic populations compared to non-diabetics, this is a comparison of about the first 8,500 patients reported from the eCipher registry in Rotterdam by Urban and colleagues. This is back in 2004. What we see is diabetics have just about worse everything. The age, the gender specifications, the incidence of multivessel disease, the length of lesions, the small vessel lesions, just about everything that we worry about as adverse predictors of percutaneous intervention outcomes are worse in diabetic populations than in non-diabetic populations, and very consistent over multiple corners of the world. And so when we do multivariable regression models of what predicts failure of a PCI, it's not surprising that both angiographic and clinically the failure is frequently predicted in significant degrees by the presence or absence of diabetes, along with other key descriptors. So then we also have to step back and recognize that what do we mean by diabetes? And there are a variety of different, I think in the past 7 years in particular, deeper understanding of the metabolic syndrome, even that predates the clinical diagnosis of diabetes. The patient under discussion here with type 2 diabetes or type 1 diabetes, that are these really the same? Well, actually, no, they're not. And Roxana Moran and colleagues looked at multivessel stenting in diabetic patients stratified by those who are on an oral agent versus those with insulin. And in fact, in the outcomes in her data, both of these were bad, even though chemically and in terms of other end organ comorbidities, we may see some differences in the patient populations in these two categories. Dean Kariakis and I in the COSTAR study performed in a drug-eluting stent study the only routine assessment of hemoglobin A1C in all patients. So in fact, we could not only identify the known type 1 and type 2 diabetics, but also document which patients had undiagnosed metabolic abnormalities, at least by hemoglobin A1C. And as he published in Invasive Cardiology in 2008, diabetic patients clearly had worse outcomes when treated with Paclitaxel-eluting stents, randomized head-to-head. The non-insulin dependent diabetics in our series had a little better outcome than the insulin dependent diabetics. But what was interesting was the very early metabolic syndromes, elevated hemoglobin A1C greater than 6.5, did not look like the more advanced or known diabetics. So there is some linear correlation with hemoglobin A1C, but there does seem to be a difference in patients who actually have full-blown diabetes, type 1 or type 2. And I think whether type 1 and type 2 really are different when you put stents in, we still have some learning to do. Importantly, in addition to the anatomic outcomes, the restenosis rates that we see with diabetes, is that clinical outcomes, Mace and mortality also, are driven by the presence or absence of the metabolic abnormality, glucose, hemoglobin A1C. And as it really gets severe or brittle, there does seem to be some relationship between the metabolic substrate and the clinical outcome with PCI. And whether that is in fact related to restenosis, once we manipulate the arteries, Don Cutlip put some correlations together, extrapolated across reports, but I think a very interesting relationship between restenosis and mortality, and then the 5-year outcome rates that we see in diabetic and non-diabetic patients. And certainly suggesting that restenosis in diabetics may actually be a little more complex as well in the subsequent outcomes than restenosis in non-diabetics. So We don't have all of the answers. I think we clearly do have some profiles, though, that diabetes, and certainly type 2 diabetes, is different than non-diabetics kind of across the board. And from the substrate, once we identify that they have coronary disease, to how the coronaries and clinical outcomes respond to percutaneous intervention.
So Mitch, is it fair to say then that the high rates of restenosis in the diabetic patient is probably multifactorial? It's above and beyond just the fact that they have small caliber vessels. We know the vessel diameter, for example, is such a big predictor of restenosis. It sounds like there are other metabolic factors, some of which have yet to be defined, that may be responsible as well.
I think that's exactly right, and I think that's some of what we may be learning, Sunil, as we look at more, for instance, variations in drugs to inhibit mTOR, and clearly with the same anatomy, understanding that diabetics have more diffuse disease and more small vessel involvement, that even when you correct for the anatomy, the aggressiveness of the disease is different, and how we manage it then does seem to make a difference. So where are we with diabetes and BareMetal versus drug-eluting stents? What do we really know? Well, from the very first head-to-head comparisons in the Sirius study, for instance, sirolimus-eluting stents and data collected by Musa and colleagues. Again, this is about 2004, but that's where we have the most data. In the non-diabetic patients, there was clearly a reduction of restenosis by sirolimus-eluting stents compared to BareMetal. And in the diabetic patients, there was as well, although in both groups, in the drug-eluting stent and the BareMetal stents, overall the diabetic outcomes were worse. The restenosis was worse. The therapeutic benefit, 80% reduction in non-diabetics compared to 69% reduction in diabetics. Is that the same? Is that really different? I think is a little harder to discern. But there was clearly a preserved benefit, at least compared to BareMetal stents, for restenosis with sirolimus-eluting stents head-to-head. The freedom from Mace by 9 months in diabetics, also summarized in that same report, did suggest that while there was a big difference between diabetics and non-diabetics with BareMetal, that there was much less of a difference between diabetic and non-diabetic restenosis rates with sirolimus-eluting. So it looks like and looked like there was some headway being made with the first generation of head-to-head comparisons in randomized trials. Very similar, frankly, with Paclitaxel and the Taxus experience. Hermiller and colleagues in Jack in 2005 summarized this was sort of the second wave of new drug approval and head-to-head BareMetal drug-eluting. Paclitaxel in non-diabetics, about a 74% reduction in restenosis. In diabetics, about a 65% reduction. And I think certainly for all of us at the time, both of these reports were really encouraging that this didn't just depend on normal metabolism, that this could take on the more aggressive disease, and that drug-eluting stents could reduce restenosis. Of course, in 2004, 2005, we were only concerned pretty much with restenosis.
Amazing, though. I mean, if you look at those numbers, the rate compared with drug-eluting stents in the diabetic versus the non-diabetic, still about 1.5 times to 2 times higher, isn't it? It's still a problem.
Absolutely, and again, this is, as you said, a multifactorial issue. There's nothing we're doing with a small piece of steel coated with a drug or bare that's taking on the underlying genetic and metabolic substrate. That's a different area of lifestyle and drug therapies. So the most contemporary BareMetal versus drug-eluting stent data is the Horizons MI study, 3,600 STEMIs. This was, of course, also a comparison of drug adjunct therapies, which I won't go into in here today, but prospectively 3-to-1 randomized in a STEMI setting between Paclitaxel-eluting or Taxus stent and the BareMetal Express platform. And within that randomization, the randomization was stratified for the presence or absence of diabetes. So while the diabetic substrate is a subset from this study, at least it was a prospectively planned and stratified randomization. Horizons overall, of course, showed, like many STEMI studies, that in 1 year of follow-up, the restenosis and repeat revascularization rates are significantly lower in STEMI patients with drug-eluting stents than BareMetal. And at least out to 1 year, as far as a 3,600 patient study can show, the safety looked pretty good the Mace that was followed out to 1 year, comparable in the overall Horizons population. So within the 3,000 patients randomized, there were 478 diabetics, not quite 16% of the population, pretty representative of the Western world. Most of these patients actually enrolled outside the U.S. And of them, 76%, 3-to-1 randomization, randomized to Paclitaxel versus BareMetal. So again, as is always familiar, as we look at the diabetic population compared to the non-diabetic population, the diabetics are worse with everything from descriptors of their body size to the presence of hypertension and other comorbidities, renal insufficiency, etc. Prior cardiovascular history, worse in the diabetics. Again, this is a more complex population. The randomization in Horizon of the diabetics stratified across the BareMetal worked well. So at least we have something pretty contemporary who are well distributed in their characteristics across the BareMetal Express or the Taxus population. And the 1-year ischemic TLR, these are the non-diabetic patients, we see the benefit of the or event rates of the BareMetal stent in yellow in this slide compared to the drug-eluting Taxus stent in blue. There's about a 2.5% absolute difference, which was significant at 1 year. And as we add the diabetic populations, again, the BareMetal stent in orange, the solid orange versus the solid blue, again, we see a much higher rate in the BareMetal stent, 11% at the end of 1 year, compared to about 5% with the Paclitaxel-eluting stent. So the Paclitaxel group, a little bit higher, but not strikingly where the BareMetal group quite a bit higher, and this absolute 6% difference again, even though the group is much smaller in size, still significantly different.
One thing that's interesting about that slide, Mitch, is that what we just talked about where we saw almost twice the restenosis rates with angiographic follow-up in the diabetic versus the non-diabetic with DES. Here the rates look very similar. To what extent do you think that this is clinical follow-up, not angiographic, and or improvement in technique of drug-eluting stent placement, a little bit more attention being paid to apposition and so forth? I mean, the drug-eluting stents here in the diabetics perform very, very well.
So I do think that there is a difference. In fact, it's interesting as Taxus went from being the investigational stent to being the control stent in a number of studies that followed, COSTAR, Endeavor, etc. It's interesting that the Taxus outcomes have gotten better and better. They're really, really good. Even in the SPIRIT studies, where Alamos-eluting stents do better than the Paclitaxel stent, the Paclitaxel stent do much better than they did when they were in Taxus 4.
Trials, yeah.
So it may be that, in fact, our attention to technique, again, keeping in mind this is almost a decade of work, so adjunctive medical therapies also are a moving target. But I think it is interesting that the performance of the Taxus stent has gotten better over a decade of use. Again, probably for several reasons, but it is notable. So if we look at angiographic weight loss where it was available, again, the Taxus versus BareMetal, there's no question that in a diabetic population, a drug-eluting stent lowers the neointimal proliferation that causes this particular measurement and its clinical companion, ischemically driven target lesion repeat revascularization. Mace, this is the non-diabetic population, again, almost identical over 1 year between the BareMetal and the Taxus-eluting stents. Mace with the diabetics significantly higher in both categories, 10 to 12%, as opposed to around 7%. Numerically, a little bit of difference, but essentially there's no difference in this small population. P of 0.18, is that really a trend? I think right now we can say there's just no apparent difference, at least in clinical outcomes. Now, is that good? Is that preserving safety while lowering restenosis? Or is this telling us that we're lowering restenosis, but we're not really treating what actually is going to bother the patient over 1 year? We can come back to maybe with our patient here today. 1 year death or MI in the non-diabetics, 6.4%, identical in the two groups. In the diabetics, significantly higher, again, 8 to 10%. Is this a difference between drug-eluting and BareMetal? No, numerically a little higher actually for the BareMetal than for drug-eluting, but this is at 1 year, not 2 years or 3 years or for the rest of their lives. And stent thrombosis, no difference at all in the non-diabetic population at 1 year, drug-eluting and BareMetal. And in the diabetic population, again, the Taxus stent at 1 year looks pretty encouraging. These are very small numbers, 4.5% in the BareMetal. On this scale, you can make it graphically look different, but numerically and statistically, there's really no difference here. At least it's not going in the wrong direction. So that's about, I think, what we can say at 1 year. This is a summary of all the randomized reports of more than 1 year follow-up, and the bottom line is we have none. So to really understand the long-term behavior in larger numbers, we don't have evidence that can help us make those kinds of decisions in diabetics. Is there a difference in platforms? Or if we talk about drug-eluting stents versus BareMetal, are all drug-eluting stents alike? And I think the first glance is maybe not. Certainly in the second generation approvals in the United States from about 2007 on, we have Endeavor, we have Zions V. These are cobalt chromium platforms rather than stainless steel, much thinner, less mechanical injury, more structural stability, maybe a little easier to endothelialize without the big mountain for endothelial cells to have to climb. The polymers clearly have been deliberately engineered to be more biocompatible. These are still durable polymers, so they are there as a provocation to the cellular milieu, as were the first generation. But if they're more biocompatible, is that more friendly to healing? And then these are new mTOR inhibitors, at least for coronary applications, in Alamos and Alamos, compared to Paclitaxel, which is really a very different drug, versus Alamos, which is an analog. Is this more the same? Is this more different in diabetics? Well, what do we know? At least for Alamos, very interesting in that head-to-head against Paclitaxel, the SPIRIT series of trials of the Zions versus the Taxus stent have been very consistent over multiple populations that Zions V is a better outcome. And yet when you look at the non-diabetic population, that's where most of the benefit is. When you look at the diabetic population, it's not so clear. The individual trials, I think you can pretty solidly say that individually the diabetic population treated with Paclitaxel and everolimus comes out about the same. But when compiled over multiple trials, it almost still starts to tilt the other direction. And you wonder, is everolimus sufficient in diabetics for the degree of restenosis that we see? Zotorolimus, a little less data available, but at least so far, compared to Paclitaxel, looks similar. And again, I think we're just going to have to follow. Of course, we have a new generation of Zotorolimus-eluting stent coming out with the Resolute platform. Same dose, same stent, but by changing the polymer, the kinetics, the duration of drug delivered clearly has affected late loss. Recently reported about double the late thrombosis rate at 1 year. So is this a problem? Is this just a wrinkle in the play of chance? Again, I think we have to understand a lot more than we do today to know whether Zotorolimus and over what time frame of delivery are diabetic arteries really influenced. And finally, I think it's important not to forget that multivessel disease in diabetics is not in all cases, in fact in many cases, is probably not necessarily ideal for percutaneous intervention. And that other options, clearly the keystone underlying all of this is not the palliative stenting or bypassing, but is the treatment of the metabolic, genetically driven side of the disorder. And we have many tools toward that end, in addition to the live longer drugs in general for coronary artery disease. In a patient with diabetes and established coronary artery disease, this is a high-risk human being. And it's not just a question of manipulating coronary sites, it's taking care of the patient. The COURAGE trial, I think, points us in the diabetic population as well as the non-diabetic population to what really are we doing with percutaneous intervention and revascularization. And I think there I'm hopeful that as we begin more to quantify how much ischemia a patient is vulnerable to, in addition to their symptomatic control, we may better understand where percutaneous intervention benefits compared to medical therapy. And then most recently, I think we can recognize a very important quantitative sort of characterization of what do we mean by multivessel disease. Is it 9 lesions? Is it going to take 12 stents? Or is it 3 vessels that would take 4 stents? This is not the same. And here I think the Synaptic study has been very helpful in a head-to-head randomization of bypass surgery versus Paclitaxel-eluting stents in all-comer patients. Non-diabetics, again, a significant proportion, but the diabetic outcome is important, is just to understand that the Synaptic score, a core laboratory-driven score, quantifies the disease in a way that we can, I think, much more realistically differentiate one patient's 3-vessel disease from another patient's left main 3-vessel CTO bifurcation long lesion disease. And clearly diabetics have higher Synaptic scores on average than our non-diabetic colleagues. Compared to surgery versus PCI, in the non-diabetic population, there is a point where the Synaptic score, the highest tercile, unequivocally does better with surgery. And in the diabetic population, that message may be even a little earlier in the Synaptic scores. The diabetic population's repeat revascularization significantly higher across categories than bypass surgery, and clinical outcomes, mortality, again, in the diabetics, particularly in the highest tercile. I think it's important to recognize that there are some times when bypass surgery, even though bypass surgery for a diabetic has a lot of other tissue healing, recovery-oriented questions and concerns, that when it comes to mortality benefit in the highest tercile of a quantitative assessment of multivessel disease, that surgery is still better. So in taking on this sort of big view of a complex topic, I think I would say that there's no question diabetes creates a higher risk metabolic, anatomic, and clinical substrate than those who do not have diabetes when we have a cohort of patients with established coronary disease. That the clinical and the angiographic restenosis rates we see with BareMetal stents in diabetics is absolutely unequivocally higher than what we see in drug-eluting stents. We could come back to whether a short lesion in a large vessel in a diabetic this applies, but in fact it does. And there's no question that drug-eluting stent benefit for reducing restenosis rates have been demonstrated in every single platform compared head-to-head with BareMetal stents. However, the long-term myocardial infarction, death, or late stent thrombosis data, right now I think the most optimistic you could say is that it appears equivalent, at least between drug-eluting stents and BareMetal stents in diabetes, but the numbers and the follow-up duration that we actually have to call evidence-based decision-making are very small and frankly are inadequate to say anything more than it sort of appears that maybe it's safe. We have a lot to learn on that particular dimension. Medical adjuncts in these patients are critical and could, I think, really be argued maybe as or more critical than what we do with revascularization as taking care of the whole patient. And with severe multivessel coronary disease, particularly quantitatively characterized with a Synaptic score, there's no question that this is not yet the realm for percutaneous intervention. Bypass has a mortality benefit.
Well, Mitch, this has been a terrific talk, and I think you covered a very, very complex topic. Just in the last few seconds, I want to ask you one question. I mean, diabetes is such a common problem. It's becoming more common. Do you envision trials of drug-eluting stents being done exclusively in diabetics rather than relying on subset analyses?
So the scary thing is that may be where we're heading, and the average age of these patients is going to drop to about 30 years old, judging, at least in the United States, by the epidemic of fat, diabetic, hypertensive children who we are raising in this country. So if we take that direction, unfortunately, we'll have all too much fuel for the fire. And we're not alone. In India, in China, I think we're seeing, again, as dietary habits from the West invade the East, smoking continues, that the presence and epidemiology of diabetes worldwide is going to give us more than enough patients to do independent diabetic studies. We're, of course, waiting for the FREEDOM trial, which is yet to be reported, but we're waiting. I frankly, for the way this trial was designed, like the Synaptic study, I think it was designed at a time we were very enthusiastic about what drug-eluting stents might mean. The last I'd heard from the FREEDOM group, the average number of stents per patient in the diabetic FREEDOM study, randomizing surgery versus stents, the average number of stents is 5.2 per patient. And in that setting, I don't think stent technology is going to win. So we're going to have too much information, or I think the way our lifestyles are taking us and our children, we may have too much opportunity to study diabetes in the future.
Great. Well, our guest faculty today has been Mitch Krukoff, one of my colleagues here at Duke. Mitch, thanks again for joining us and for such a great presentation. Until next time, then, from all of us here at Duke, this is Sunil V saying thanks for joining us and take care.
Thanks, Sunil.